Good morning, everyone. My name's Mary P. Mills. Welcome to the Tortoise Global Health Summit and our third session of the day, which asks, are we ready for the next pandemic? It's clear to me, as I'm sure it is to others who've joined us this morning, that with the vaccine, there's a sense that COVID-19 might not be preventable, but controllable in the future. But having experienced a global pandemic, I think what's on all of our minds is once we reconnect and go back to the life that we had before, is the next pandemic just a flight away? And if so, how ready are we? And we've got three great guests who I'll just introduce in a second to help us answer that. But before we do, just with other sessions, I'll just go over a little bit of housekeeping. Please let us know if you'd like to talk. You can raise your hand or get involved in the chat where my colleague Kim is marshalling and curating. So do please speak to her there. And just as in other sessions, we record these in case we want to use them on our digital platforms later. So to introduce our guests, thank you for joining us. Dr. Jennifer Cole, who is a research fellow at Royal Holloway, who in the past has done research for governments that's informed and critiqued the emergency pandemic preparedness plans. Caroline Cake, who is CEO of Health Data Research UK, and Richard Gunderman, who is the author of Contagion, Plagues, Pandemics and Cures from the Black Death to COVID-19. Thank you all for joining us, Richard. I know it's incredibly early where you are, so thanks for getting up for us. Jennifer, I will start with you. As I said, you've written about aspects of pandemic preparedness and all the aspects and planning that goes in necessary into being prepared for something like COVID, including scaling up hospital capacity, preparing temporary hospitals like Nightingale, increasing lab capacity. And in spite of the many bad headlines, am I right in thinking that to some extent the UK was incredibly well prepared for a pandemic, in fact, among the most prepared in the world?
It's certainly headed up the pandemic preparedness plans. And I think one of the things in retrospect, and I would absolutely say that, I didn't see this coming before, and so I'm not surprised that anybody else in government didn't either, is I think the one thing it did show is that the plans were very much health sector specific plans. The plans were for setting up a Nightingale hospital, which they did fantastically within weeks. It was for developing and distributing a vaccine, which has been done in a time that 5 years ago would have seemed impossible. Where the plans didn't hold up so well, I think, is in the parts of it that were outside of the health sector. So, for instance, the private care homes. How easy it would be to distribute food from supermarkets, how you would actually encourage people to comply better with some of the public health behaviours they were asked to do, all of which are incredibly difficult and also are incredibly specific sometimes to the particular type of disease as well. There was a lot of criticism that the plans were for pandemic influenza and it was a coronavirus. A lot of that on one level doesn't matter because you're dealing with how many ill people does the health service have to cope with. And the other side of that, which is how much is it airborne, how much is it passed through touch, is it passed when you're symptomatic or not? You can't really predict in advance. It will be different for every single different disease. So I think what we can do is look back on the lessons identified and look at how we can modify those for the future. But the other thing that plays into that is how much time do we have to practice and prepare and exercise in the way that the military exercises constantly, which is why the military is so good at dealing with things when they do happen. When you have a health service that is absolutely stretched to capacity and they can barely cope with their day-to-day level of patients in the first place, they just don't have the time to release staff to go and do pandemic preparedness exercises. And I think what this has shown a light on is where there are real vulnerabilities within a health system. And that's what we need to strengthen if we're going to be prepared for the next pandemic. And to look at that day to day rather than just the strategic plans.
These exercises you mentioned, so it's quite interesting to read in the piece that you wrote that there was an exercise, a pandemic exercise conducted in America, or at Johns Hopkins University in America, where almost the week that the COVID-19 story broke, and how useful actually are they, and what do they involve?
They come in different ones. The one at Johns Hopkins was a tabletop exercise. So what you normally would do is get together a lot of the strategic planners, and I'm sure the other speakers here have probably been involved in such exercises as well. And you would talk through some of the issues. So one thing you might decide is what would you actually need to know? And you could think about, well, actually you'd have virologists and epidemiologists involved. So the people who are on SAGE. And one thing you could think is, well, what else might you need? Is there any obvious expertise that isn't in that group that as you're playing through the exercise, you suddenly realise that you would really need? And that might be, for instance, you might have the CEO of a social media platform. How do you actually quickly contact social media platform to get messages out across their platform? Would they be willing to? Do you want to build up relations with them in advance? One thing I think, if we went back and looked at those exercises, is the healthcare, the elderly home care sector in the UK probably weren't involved in them. And they're perhaps a group that in retrospect should have been. So you might want to think about who are your most vulnerable groups and what makes them vulnerable. And how do you then try to plug some of those vulnerabilities? The tabletop exercises tend to be very high level, as I said, very strategic. What you wouldn't necessarily get is ward nurses, in a care home workers, and they would sometimes be able to bring a different view as for instance, if they're being told to socially distance, but they have no choice but to travel on public transport because they don't own their own car. How is that going to affect the likelihood of them becoming infected and passing it on? The other side of that is live exercises, which the military do a lot, the fire and police would do a lot, ambulance service would do, for instance, a mass casualty shooting or a terrorist bomb. It's much more difficult to do those with infectious disease because infectious disease doesn't tend to happen in the period of an afternoon. So how you would actually play out something like the pandemic, where you have 3 months between the first case, 1 or 2 cases in the UK, it becoming an issue where the hospitals don't have enough, while you're trying to work out the genome of the virus, what PPE you need, exactly how it spreads, is much, much more difficult to do. But again, I think it would go back to how much time do you actually have to run those exercises, and how able are you to allow staff, to release staff for the day to go for them. And to some extent, I think one of the problems, and it has been shown from those exercises we've had in the UK as well, is the plans for them nearly always get scaled down because there just isn't the staff capacity to put into them in the way that the exercise planners would like in the first place.
Okay. Well, I mean, in fact, somebody in the comments, Lynn Stagg, is making a point about the running down of the NHS. And perhaps, Lynn, we can come to you in a little bit and talk about that, because I'm sure that is part of the conversation. But can I just ask you, Jennifer, as well, that it's noted that some of the countries that did best are those that locked down early, locked down hard, and didn't try and balance the lockdown with the economy. And those countries are really quite closely connected with those that have experienced SARS and other pandemics and just didn't want to take the risk, whereas there was probably a fear in the UK and some other countries of the fear of crying wolf. Do you think that we will now learn from our mistakes for the next pandemic?
I think there's definitely a once bitten, twice shy. And so those countries that had experienced SARS wanted to make sure it didn't happen again. One of the people in the chat has mentioned that didn't lock down at all, Sweden. Sweden is actually an interesting case. It actually falls completely on the middle between the two. So there are advantages and disadvantages to it not locking down. And also, when it says it didn't lock down, it didn't legally lock down. Actually, the people, what we've heard from anecdotes from people in Sweden, is that actually people socially distanced in Sweden. So although it wasn't imposed, there was actually more lockdown than the media gives the impression of. But I think, and as I mentioned when we spoke yesterday, I think swine flu might actually have made things worse, because I think had swine flu not happened, we would have perhaps taken more drastic measures. But because swine flu came and wasn't as serious as people had been expecting, that didn't help the idea of the exercising and the planning and pandemics being top of the National Risk Register to be taken seriously. And I think there is the danger that the next pandemic may actually be a mild one again. And so if we did go in with those very harsh, very draconian measures to begin with, we might then be faced with a very mild pandemic where, again, it's criticised for being taken too seriously. And so I think it's a very, very, very difficult balance of that. Again, the questions that of the countries did better, Taiwan and Germany have been mentioned in the chat. One of the things they both had in common was very, very strong track and trace. And I think that's something, again, that perhaps we missed in the UK. The countries that went for track and trace seem to have done it very well. And it's definitely with the stronger leadership that's been mentioned. As you mentioned, it was decisive. The countries that closed down and did it well, did it decisively. They closed down, absolutely. They didn't try and balance lives against the economy. We're going to shut down the economy for 2 weeks completely. Every shop is going to be closed. People are going to be in their houses. The army are going to deliver food. In China, there was a lot of criticism of pictures of, quite draconian police measures. It worked, it absolutely worked. It's much harder to impose that if you're trying to do that whilst keeping some of the economy open.
Okay, thank you, Jennifer. I'm sure we'll come back to you in a bit. Caroline, can I come to you now? As we just discussed, there's these tons of exercises done, and we've been seeing practice, the evolution of a lot of these skills and disciplines that people have been talking about. But there's so much unpredictable in a pandemic, and I've heard you say that who would have thought that the number one topic associated with COVID in the news headlines is free school meals and Marcus Rashford in this country, and that was something was completely unpreparable for if you're looking at a pandemic in terms of just the health service. So how much unpredictability is there in pandemic planning, and how much can we prepare for the next pandemic?
Thanks, Mary, and really interesting kind of hearing Jennifer's perspectives and things on that. I think, I'm talking from having gone through this one. So in terms of generalizing and things more broadly across, it'll be interesting to see how relevant it is for our next one and things on there. But having gone through this the first time, I think there were certain things that really helped we had a series of things that were up and running that could be quite rapidly pivoted to this particular purpose. So I've been coming through from looking at the data perspective, particularly, and the seeing the things that were in place for other aspects and other purposes, data that was being collected that could then rapidly be used for to understand what's going on. But I think what was, as we were going through the early months, the number of questions that we just didn't know the answers to and needed the information to be able to understand. So what was going on with different ethnic groups, you could start seeing patterns starting to happen, but you just didn't have the evidence at that stage to go, is it an ethnicity issue? Is it an occupation issue? Is it a socio-economic issue, or an age issue, or a male-female issue? So there were all sorts of questions that we were needing to understand as you go through in this pandemic on that, to then be understanding, have we got the right treatments in place? Are we taking the right actions? What are the indirect actions that are happening at the moment as a result of the actions we're taking? So as we're starting to see the impacts on cancer. So I think there are certain things that you can have set up that enable you to be able to answer the questions rapidly, but know that the answers might be different for that specific question in a different pandemic. So and that therefore would then kind of influence what comes out of it. So very early on, are we recruiting the right sorts of people to the trials we're needing to be able to answer those sorts of questions? So there are all sorts of things that I think you can be well set up for and have the processes for that, but actually they will look slightly different depending on the actual pandemic.
Okay, and as you said, you've been looking at this from the data perspective. I've never seen so many sort of graphs and charts poured over and shared across, social media and the news. And this has very much been a sort of, data-led pandemic. Now all that sort of data is kind of switched on, looked at. Do you think we're not going to stop tracking all those virus mutations, and it all puts us in a better position for the next time?
it will certainly tell us as we look back as to what things were really useful at looking at in there. So there were all sorts of, in there, there have been things that have been incredibly useful, and then there have been things that have kind of been started up and slightly withered on the vine and things in there. So it's a kind of mixed bag of what's really been valuable and useful. And I think it would be really helpful to collect back and say, of the things that happened, which things do you want to make damn sure you've got set up and ready to go or continued going forward. There are all sorts of aspects on kind of the information governance side, on what is contained, what can continue post-pandemic, which need to be worked through and thought through, that will be, because yes, how much do we want all of this to carry on? How much is appropriate once circumstances change? So that all needs to be worked through. And I think it would be helpful to have a collective discussion on what is the right and appropriate balance. And because there was really quite a big change as we went into with the kind of new regulations effectively going into the emergency requirements.
And this is a question I think I'm going to try and ask everyone, all of the panelists at some point. If there was one thing that you could do, you would choose to make pandemic planning better in the future, what would it be?
One thing. I think having a means of prioritizing the questions and being really clear on which questions do we want to answer and have we got the right data to answer them.
Okay.
Having that, just because one of the things in the early stages, you can quite quickly get quite a chaotic process happening because everyone's asking all sorts of things. So how are you prioritizing? What are the really good questions? And then we need all the resources set up around answering those.
Okay, thank you so much. Richard, I'd love to come to you. I know it's bright and early where you are in America. So the first thing I'd like to talk about is one of those graphs that was a part of the slides at the start. Possibly the most interesting graph to me of the pandemic, which is it shows pandemic preparedness against deaths in various countries, and actually it's almost a mirror image. If you have time to go and look back at the slides, the most prepared countries for a pandemic were the US and the UK, and the least prepared was sort of the continent of Africa. But in actual fact, the US and the UK have had the most COVID-related deaths, and Africa has had among the lowest. It's quite counter to what you'd imagine, and there might be all sorts of explanations to it, including age of population. But Richard, would you just give us your sort of take on that graph?
Well, I think you make a very good point, Merope. One is that the population in Africa is in fact on average quite a bit younger than the population of countries like the UK or the United States. And of course, we know that the risk of death with COVID infection goes up with the age of patients. So that would be one reason that we might have a high degree of preparedness, but also a higher death rate in the United States. Another factor might be the degree to which the population has been exposed to coronaviruses in the past. So, we have very high standards of sanitation and hygiene and so forth in places like the UK and the United States, which may be preventing us from acquiring, say, coronavirus infections that would otherwise render us at least partly immune to the current coronavirus infection. So in a sense, living in a hyper clean country may in some ways leave us a little bit more vulnerable to viruses to which we otherwise haven't been exposed. And then I think there are also, certainly, as both Jennifer and Caroline alluded, there are political factors as well. I think in the UK and the United States, there's somewhat greater resistance to imposing public health measures that would severely restrict the ability of people to go outside their home, say to go to school or go to work. So we tend to think of pandemics as strictly biological problems, matters of infectious disease, but as we've already discussed, many other factors, economics, politics, culture, they all impinge on the way we respond to a pandemic.
Okay, and Richard, I should mention that we talked before this before this meeting, and I wrote down something that you said which rather struck me, which is Western developed societies have managed to pretend they're interested in a problem of pandemics but not do enough about it. What if that's the case, what would you say, what changes should we make to do enough about it for next time?
Well, one reason pandemics are such a big problem is that they're relatively infrequent. So their consequences are sometimes disastrous, like the great so-called Spanish flu of 1918 that may have killed 50 or perhaps as many as 100 million people worldwide. It was a disaster, and people certainly had it in mind shortly thereafter. But as the years and decades go on, we tend to forget about them. So I think it's difficult for us to convince ourselves that we need to be prepared for a pandemic, because sometimes for whole generations, there's no living memory, or at least a diminishing living memory of how catastrophic they can be.
Okay. Jennifer, can I just come to you quickly, because I think you want to counter one of the points that Richard just made.
Yeah, Richard, I just really have to pick you up on your use of the hygiene hypothesis there. That absolutely is not held up scientifically in this pandemic. There has been some evidence that actually the common cold coronaviruses are providing some protection, and certainly absolutely no scientific basis that is the case in Africa. And I'm sorry, but I really do have to counter you on that.
Jennifer, while I've got you still, can I just bring up a point that you mentioned before? Two areas that the government that were criticised for, particularly in this country, for the lack of PPE and testing capacity. And as you mentioned before, in the case of the former, a lot of that was among care home areas, which is completely privatised in this country almost. So I think there's a question, it's a sort of political question almost, which is, how much private sector pandemic preparedness should be mandated by government in this and other countries, I expect. How much is it not just a problem for the public sector?
Yeah, I think it is a really interesting political question as to what extent is the public sector responsible for the private sector's behaviour, for want of a better term. And I think some of that involves bringing the private sector into some of those planning discussions and building up good relationships. But it also comes back again to, fundamentally underneath this is the investment in health services. It's not necessarily that the elderly care sector is privatised. It's that it's privatised as cheaply as possible with as many corners cut as possible. And a colleague of mine who actually works particularly with elderly care service delivery said that, one of the problems is the only way as a private sector that you can make a profit from running an elderly care home is to cut the quality of the service and to pocket some of the money that should be going on care. So the minute that service is privatised, rather than comes under the NHS and the public sector, it is going to be cut back and corners are going to be cut. And very interesting data, which may well be available, I haven't particularly looked for it, is if you look at the number of deaths in care homes where reasonably affluent, well-off elderly people were, as opposed to the lower socioeconomic care homes that were, shored up by the NHS money, you would see a very, very different pattern of deaths in those homes. You would certainly see care homes where, none of the residents had died from COVID, where there was enough PPE, where there was a much higher standard of care. And that comes back to a lot of this, and it comes right back to things that were said in the Ebola outbreak, that it's not necessarily the virulence of the disease that's the challenge, but it's the lack of availability of the healthcare sector. And the more investment you put into prevention, whether it's for infectious disease, non-infectious disease, right across the board, the money spent on prevention is between $10 and $15 reward for every pound you put in. And what we're seeing at the moment is healthcare sectors that are being stripped back. The slides you had at the start about the number of beds, the number of nurses, and it's not surprising that the capacity is not there to deal with it. So it's not necessarily the pandemic. It could have been a bad seasonal flu that would equally have stretched the health service. And if the investment's not there, you're going to see those vulnerabilities exposed.
So I think that seems like a good moment to go to Lynn Stagg, who made that point right at the start. I don't know for people who, Lynn, if you are there.
Yes, I am.
Hello. You made a point at the start about, NHS funding and what impact that might have had. Would you just sort of outline it for us here?
Well, my point was that basically I actually have an interest, if you like, in trade unionism, and I've seen over very many decades the complete running down and denigration of services to the extent where they only need a certain number of beds, and it's perfectly clear that there are now not enough beds to deal with anything. But also the fact that basically people are working who are not being paid a lot of money, and seems to me that the people who run the services are being paid far more than the people who are actually doing the work. So again, I think it's just a question of having to say to oneself, what do we value most? And basically, from my point of view, it's the fact that basically we couldn't possibly be prepared. I mean, a lot of people in the world would, have such regard for the National Health Service and everything that it embodies, but at the same time, nothing can be as good if you actually start saying that you don't have enough money to deal with crises. And we know that during this crisis, that basically a lot of people have they're working so hard that whether or not we get through the pandemic, they won't be able to work to that capacity. They'll be completely burnt out.
Thank you. Thank you, Lynn. And I think you're not wrong, just to reference the slides at the start that Jennifer mentioned. Number of hospital beds in the UK have halved in over 30 years. And the NHS has little spare capacity to cope with the pandemic, let alone pandemic planning. What is the solution for that, Jennifer? I mean, is it a funding? This talks back to our very first issue today, which is it a funding issue?
I think it absolutely is a funding issue. I think there's no question of that. And there's also, I think, a question of what parts are privatised and are they the best parts to be privatised, and how could they be privatised? The idea of the unionisation was mentioned. I think if you are going to go into the private sector, something perhaps more like the old friendly societies of between the war, putting social care out into communities that are run by communities themselves, not by the private sector. So perhaps putting it more to the local authority level, if you want to take it out of centralisation and central government, put it down to the local level, but keep it within the public sector, so that healthcare is not seen as something that you make a profit out of. And also if you perhaps try to break down some of the silos between government departments, actually start to look at where would the preventative money be best placed? Is it in better housing? Is it in better school meals? Is it in better nutritional understanding for children? So again, one of the vulnerabilities that COVID has exposed is the non-communicable diseases, the levels of obesity and diabetes that make people vulnerable later on. And actually, preventing that goes again right down to that, the free school meals idea, the teaching children about good nutrition, teaching them about exercise, and making that available to them, making sure that you can, if you're living in an area where it's not easy to get to the supermarket, you don't have a car, you don't have much money, and you don't necessarily have good cooking facilities or freezer at home, how can you actually eat well? It was one of the things that was quite shocking. I did a piece of work recently at Royal Holloway on health for refugees. And we were looking at, what we started off looking at was how easily, for instance, could they access, if they had chronic conditions and they were moving from one country for another, could they get consistent drugs? What happened if they broke their glasses and they needed a new pair of glasses? The thing that came up from everybody again and again and again was the access to good cooking facilities. And that's, too many people in the UK are living in temporary accommodation with a 2-ring, burner stove without an oven. They have to put 50p's into electricity meter to make it work. They have to go to a supermarket that may be further away than they can walk, and they don't have time because they're working 3 jobs to try and make ends meet. They're dependent on the fried chicken shop, which is the only thing that's on their way home from work. And now that's closed down. And this ties into, again, perhaps some of those issues around food security that's led into Marcus Rashford and the school dinners. The people who are involved in some of those strategic level exercises have probably don't have a clue what it's like to be a family whose child is dependent on free school meals. They don't speak to people whose children are on free school meals. They have never experienced it. And actually understanding that from the ground up on a whole of society level as to how is that health embedded in every single aspect of your life, from the moment a child wakes up in the morning to the minute they go to bed in the evening. How is their housing? How is the food they eat? How are their parents' occupation? Leading into the health that they will have as an adult, and making the country healthier across the board do that is again something I think we really need to move forward into from this pandemic.
Okay, thank you. Richard and Caroline, I'm going to come back to you in just a second, but I'm hoping we've got Alex Coley available to talk. Alex, you've been writing that you were a civil servant, and pandemic planning was top of the list when you were a civil servant. And in fact, you worked on the swine flu pandemic. Would you just talk us through a bit about your experience?
Yeah, I would just become a civil servant. I'm just going to shut the door because I've got noise in the background here. I'm a civil servant in the spring of 2009, and very quickly we had swine flu appear. And because it was something that government had on their risk register and was prepared for, there were plans in place, and there were a lot of the infrastructure that's missing now was there, like having a government communications department, having a Department of Health that was ready to respond. And it was, so it's a huge frustration to me to see not only that it doesn't seem to be that there's the infrastructure or the preparation, but the communications is sort of, the Prime Minister's SPAD has a couple of mates that do social media and we'll get them to do it. That's what it looks like to me from the outside. It doesn't look as though there are professionals who are having a sort of sober and clear route to what they want to achieve, what the outcomes they want, and are using proper science to achieve those outcomes. It looks like I've got some mates that do a bit of election stuff on social media. We'll just get them to do comms on health. That's what the social media campaign looked like. It was frightening, really. And when I was working on this, I said very, very new. We built the online pandemic flu service in pretty much days, using an old, are you having a heart attack? You could go online and it would tell you what to do. And it was on what, tech people call a wet piece of string. It was not very strong, the infrastructure. It was in a data center in Cardiff. We moved it all across to DirectGov. If you remember DirectGov before the government digital service, we had Akamai servers. They had 100% uptime. So I was tasked with moving it all across, putting a better design on it so that people could get Tamiflu if they needed to, and they knew what number to ring in, what part of the UK, depending which of the 4 nations, what process they should go through. I got to test it with dummy addresses to actually go through the process and see if I would get some Tamiflu if I went through that process. It was all done in a really structured way, and you felt like you knew what you were doing. And the CERC, who are a team within Cabinet Office, Security, Intelligence, Resilience, they had their weekly conference call, and the Department of Health, they set up their own competing conference call, but we managed to get them to talk to each other. And you felt as though all of the things that should be there were there, that it was all happening, and that you would see the outcomes on TV or on website. You'd actually see, okay, we had that meeting, we discussed this, and then the public can see that. It doesn't feel like any of that's happening right now. I'm not in government, so I couldn't tell you, but looking at it from the outside, it looks like there's a lot missing, and that it's really disparate, and that each department's kind of doing their own thing, which they always do anyway, but no one's trying to sort of force them together. It's just if it all goes wrong, then Cabinet Office will step in and sort of bash heads together. That's not the way that you handle a pandemic. So I find it all quite frightening, and without getting political, it feels as though the constant just cut, it's removing capability from the system has now had a proven effect. People have died in huge numbers because capability has been removed. You can't you can't look at efficiency on a balance sheet and go, we save money. You don't know if you've been efficient until it's tested, and it's just been tested and thousands of people have died. So that's what makes me really angry, that there's this fallacy, there's this pipe dream that you can just cut out waste and red tape that is assumed to be there, and you get value back for it. And I hope that what we see out of this is that in future there's the proper investment in the skills and capability so that we are ready for it. It's an investment. It might not happen, as the gentleman in America said. This doesn't happen very often, but you have to be ready for it when it is. Even if that means spending money for 10 or 20 years without seeing it impact, you have to have that ready to go.
Thank you. Thanks very much. Caroline, from your experience, does that bear out that sort of lack of joined up thinking between sort of government? Is that what you see at your end?
So I'm thinking from the science and the data side, and I actually think it's been quite phenomenal. So in terms of the how well, so I'm sorry if Alex has had that experience and things in there, but certainly from seeing what's gone on across the whole of the UK science community has worked incredibly effectively together, working across a whole range of different issues in a very coordinated way. So for example, we have 70 or 80 people who are reviewing and working across multiple disciplines in health data science, meeting weekly, reviewing the different aspects, working through the key questions. We've got the data sets coming on board systematically across all the data custodians. This has never been done in the UK before. So we've got, and across all 4 nations, bringing together, so ensuring the data sets are coming board, access processes are being streamlined, so people can be working on the research programs coming through, being funded using urgent protocols and approaches on there. So I've never seen this scale of coordination happen, and it's been phenomenal. So, and hence, in the UK, we made some of the first discoveries. So the dexamethasone discovery through the recovery trial was was the first globally, really, to be actively saving lives as a result of that. So yes, there clearly are things that have been working. I think the pandemic has made stark many of the social challenges that we can see that pre-existing the pandemic and have been very stark through this. But I think some of the response really has been world leading.
Okay, thank you. And I Jennifer would like to come back to you as well. And then I'm going to come back to Richard, I know, who's I haven't spoken to for very long. So Jennifer, just have you wanted to say something to Alex as well?
Yeah, just to Alex, I could not agree more. I'm assuming from what you say, you probably worked with people like Carol McCall and Dave Barnes in the Cabinet Office and came across Ian Brown. There used to be an entire communicating in a crisis department within the Civil Contingency Secretariat that was scrapped not long after swine flu and scaled down. And again, I'm not sure how much of that was because swine flu has been seen as a little bit of an overreaction, and how much of it was just kind of scaling back in general. That, you know, there was a huge influx of cash, particularly after 9/11, for what was called an all of society approach, that gradually, bit by bit by bit, got chipped away until it went. And definitely the communicating in a crisis group that Carol McCall ran fed in then also to what the BBC had, which was a kind of BBC version of that, which was led by a guy called Ian Cameron. And they were fantastic at communicating, particularly kind of with the public and at that local level, and working out, you know, what were local issues, what would work, what channels did people use, how did they deal with it. And it all went, you know, it all got stripped away. And actually, you know, when I was at RISI, which was a policy think tank I used to work with, what started off being a group of 40, by the time I left RISI was down to about 2 or 3 people. And that was, you know, it was purely government cuts. You know, it was purely looking at, you know, there isn't enough money to go around, and so some things have to go. And those were some of the things that went. In terms of the, you know, quite a lot of people I've noticed in the chat have been mentioning the local resilience forums. The local resilience forums are a great model. Again, they are chronically underfunded. You know, there's absolutely no money for them. Some local resilience forums meet for half an hour once every 6 months, and half the people on them won't turn up because they, you know, they're so stretched for work they can't take half the day off to be there. If we want these systems to work, we have to invest in them. And that's more about just sharing data and joining up the data. It's actually taking that offline to see how that actually works on the street. How do community groups, how does this actually affect people at the community level? And if we're not doing that, we're not going to be prepared for any health emergency, a pandemic or anything else.
there's obviously a theme developing here around NHS funding, although and communication. But although it seems that from Caroline's point of view, the communication around the scientific community really stepped up. Just back to you, Richard. You made a point when we talked before about to really be ready for the next pandemic and also to prevent it, we need to have a different ecological framework, stop forcing species into smaller areas. Would you want to just talk about that for a second?
Yeah, well, if we keep encroaching on the habitats of other species, like, say, birds or bats or pigs, from which these viruses often jump to humans, as we encroach more and more on their habitats, we may be increasing the probability of future pandemics. So it's not just how we respond once a virus jumps from, say, a bat to a human, it's also, are we creating conditions in which such jumps are more likely?
Okay, and your other key sort of takeaway of pandemic preparation is to realise that pandemics just viruses don't respect national borders, and that is one of our sort of problems when we prepare, that we're too nation state focused. Is that right?
I think that's absolutely right. Viruses and bacteria and the vectors that transmit them don't bear passports. You know, they're no respecters of international boundaries. For that matter, they're no respecter of socioeconomic class, ethnicity, faith tradition, what have you. And I'm not suggesting we do away with nation states, but there are some problems that humanity faces that can't be addressed best by individual nation states. And we really need to get countries to work together to share information, not to suppress information, and to coordinate public health efforts if we're going to respond effectively both to this pandemic and others we confront in the future.
The whole respecting and shutting down borders is a really key point. And, you know, actually, Jennifer, when I spoke to you before about this, I said, would shutting down borders internationally have made a much bigger difference at, you know, a coordinated shutting of borders have prevented COVID-19 being as bad as it has been, and would we do that again in the future? And what you said was quite interesting about each country's own responsibility to its own citizens. Would you just say what you said to me?
Yeah, I'm still unmuted. Yeah, there's always kind of talk of shutting down borders, and I absolutely agree with Richard that they don't, you know, viruses and bacteria don't respect international borders, they move around. One of the issues with, if you close down borders in a pandemic, is that traps countries' own citizens in other countries. And inevitably there would be pressure on those countries to then bring their citizens back. We know from disease introductions into the UK that diseases are more likely to be introduced into the UK by a British citizen who's been on business or holiday overseas, bringing that disease back, than it is from a diseased foreigner who's coming to the UK on a holiday or business. So the idea that kind of shutting down borders would stop the disease spreading only works if the whole world shuts down all travel and you don't start repatriating your own citizens. What you certainly could do is to then, if the whole world agreed and you did it that hard, to then perhaps quarantine citizens at the departure city, wait until you knew they were out of the quarantine period and they weren't infected, and then bring them back. But politically, that is a very difficult place to be in. And also, by the time it was confirmed that there was human-to-human transmission with COVID-19, it was probably, unfortunately, already all over the world. So again, in a future outbreak, it would depend on whether there was asymptomatic transmission, whether there was human-to-human transmission, at what point you're most infectious. And going back to the idea of we don't necessarily have all of the answers at the start. We could shut down the entire airline industry for a month and then find out that had been absolutely no need to. And how, you know, politically acceptable or not would that be? So again, it's a very difficult issue, and there's no easy movie plot answer to it. It has to be kind of considered for each situation and each pandemic as it comes.
And just the last point here, because I can see we're coming to the end. One thing I hadn't realised is that pandemic planning is a mitigation tool. It's not a cure, in fact. And people like you involved in pandemic planning assume that pandemics can't be stopped; they can only be slowed. Is that right?
I would say so. Yes. I mean, the idea that again is it's a kind of a movie plot idea that they can be stopped. I think mostly what they can do is be slowed. And if you look at swine flu, it eventually became endemic. And that's probably what's more likely to happen if it's transmissible enough, which with SARS and MERS, they won't. They're not easily transmissible. And neither was Ebola. Ebola was actually quite hard to catch if you had a decent hygiene where you were, which most of the areas in West Africa didn't. If it's that transmissible, you nothing will stop it, and so you're constantly into mitigation mode, and it's just kind of how do you mitigate that? Because again, with track and trace, you would be able to keep outbreaks reasonably small, but again, for how long would you be able to do that? You would only need to miss 1 or 2 people on track or trace, and again, it would be spreading everywhere. So I think the planning is, how do you plan the best you can? There is never going to be the ideal solution, and I think if we spend too much time blaming people for not having an ideal solution, we'll miss the opportunity to focus on the things that could be strengthened or could be done better next time.
Okay, thank you so much, Jennifer, Caroline, Rich, for your measured and thoughtful responses about what we did right and what we did wrong and how we could do better next time. I think you all made some fantastic points about, encroaching on our environmental world, better communication, and where communication has worked in the scientific community. And actually, Jennifer, so much about what we said is about funding, and the very first session that we had today at the Health Summit, whether we should change the funding model for the NHS and how health is really embedded in every aspect of our lives. And that has to be part of our pandemic planning for the next pandemic, whatever that might be. Just to say that we tend to go dark now for the next sort of 14-15 minutes. My colleague Matt Dancona will kick off the next session, which is at midday, on health inequalities. I expect we will be touching on some of the same topics here. It's understanding how everyone can access the help that they need. If you're not a member, do please join us. Feel free to join us for 30 days. I think my colleague Kim is able to share a link in the chat, but do stay with us even though we go dark and play songs now. And I hope to see you again at other sessions later. Many thanks for joining us, and thanks again to our speakers.